Students, it gives me great pleasure being with you all today. I have been treating TB patients for more than 30 years, and this topic of evolution of chemotherapy in the treatment of TB is very close to my heart. Hope I do full justice to this topic. You know, prior to 1940, the only treatment that was available for TB was absolute bed rest, good food, good air, sanatorium line of management, etc. What we were aiming at the end of this was early sputum conversion, and so that they become non-infectious, and also a good cure rate, and also a short duration of treatment, and also after they get treated their quality of life is reasonably well. Most importantly, they should not go in for relapses. Now, all this was not feasible prior to 1940 because the sanatorium line of management did not offer much of a cure rate, and the relapses were high, and the patients who were cured, also the quality of life was not that optimal. With this in mind, in way back in 40s and 50s and 60s, there were three main research institutes all over the globe. One is BMRC, London, and the second one in Chennai, Tuberculosis Research Center then, now it is called National Institute of Tuberculosis Research, and also studies done in Hong Kong. These three places did a remarkable number of trials, and they evolved the principles of chemotherapy, how long to treat, how many drugs to be given, which is the preferred drug, which drug prevents relapse, which drugs gives you earlier bacterial load clearance, etc. So today briefly we will have a look at these studies and how the principles were evolved in a very broad way. Now, you all know tuberculosis is an ancient disease described in Vedas, described in our scriptures thousands of years ago, and traditional management, rest and diet, and drugs are available since 1940. The main drug, the first trial, BMRC trial, was started with streptomycin, and they were very happy when streptomycin gave very good results. Patients became smear negative, and clinically they improved. But this happiness was short-lived, and all these patients who became smear negative after a span of 2-3 months again started having positive smears and positive cultures, but also they were streptomycin resistant. So this was the first trial, in fact first controlled clinical trial for all the diseases, and where in the case of tuberculosis it showed that one drug therapy is not at all adequate in the case of TB, and this may result in development of resistance, and patients will come back to you again with the disease. However, along with streptomycin, we also had PAS, isoniazid, thiazolone, and we gave combination, either 2 drugs or 3 drugs, and suddenly we could see cure in the treatment of tuberculosis. The problem was here the duration of treatment was quite long, and they had to be treated at least for 18 to 24 months, taking these injectables and oral drugs, and PAs was very difficult to take. In 1960s, rifampicin came. That was one real boon for the treatment of TB. The rifampicins were so effective, they killed all the bacteria within 6 hours. Patients became smear negative in a short spell, non-infectious, and the treatment could be shortened to 6 to 9 months. So the arrival of streptomycin in the scenario of TB treatment made a big change, and even today there cannot be a regimen without rifampicin. In 2013 and afterwards, we had lots of cases who are resistant to rifampicin and also INH, and this resistant to RIF and INA is called multi-drug resistant TB, and these patients, the treatment became very difficult. The number of available drugs are also, even though many were not very efficient. The newer drugs like bedaquiline and dilamanid, they were approved in 2013, and there number of trials are going on with these two drugs, and there is again a ray of hope in the treatment of drug resistant TB. So, to summarize, whatever has happened so far, 1940s, late 40s, it was streptomycin monotherapy. First time we could show smear conversion and culture conversion. However, they relapsed. 1950s, 2-drug treatment for 24 months. 60s, 3-drug treatment, streptomycin INH pass, and the duration was reduced to 18 months. And late 60s, it was 3 drugs, duration 9 months, and in 70s, with the arrival of rifampicin, the duration shortened to 6 months. So, you could see the number of drugs are increasing, but the duration of treatment is correspondingly decreasing. Now, the regimens once again, 46 only streptomycin, 52 streptomycin INH pass, and then pass was replaced with ethambutol. So, the duration could be cut short to 18 months. Addition of rifampicin to streptomycin. Here, the advantage was streptomycin had to be given parenterally, and it also had lots of adverse reactions like deafness and giddiness. So, with the addition of rifampicin instead of streptomycin, the injectable could be avoided. At the same time, the duration also could be shortened. In 80s, streptomycin was replaced with pyrazinamide, and once again, the duration was shortened to 6 months. Now, this picture clearly shows the various time points 1942, 52, 55, 57. Down the line, you can see how the drugs were introduced, kanamycin in 57, ethambutol in 61, gapreomycin, etc., and how the regimens keep changing over the period of years. Now, currently recommended treatment regimens are the results of numerous clinical trials, as I told you, from BMRC, TRC, Hong Kong, etc. So, what are the principles of the treatment of TB? Now, that was evolved from our center in ART. We have significantly contributed towards domiciliary treatment. We had a study where we have shown should the patient be admitted in sanatorium or whether he can be treated on a domiciliary basis, and we clearly showed that over a period of 5-year follow-up that patients' recovery, relapse rate and their infectivity, everything was comparable between those who are admitted and those who are treated on a domiciliary basis. So, domiciliary management is as good efficacy wise as compared to sanatorium line of treatment. This was one major contribution from our center. Now, we have done a number of studies using rifampicin and pyrazinamide and shown that short course chemotherapy consisting of 6 to 9 months is as good as earlier regimen or even better than the earlier regimens for not only pulmonary and also for extrapulmonary TB like TB meningitis, TB brain tuberculoma, abdominal TB, TB lymph nodes, etc. We would like to highlight, we have emphasized the need for supervised treatment, what we used to call DOTS, directly observed treatment strategy. We thought giving long-term treatment for 6 to 9 months, if you supply, the patient may not take the right dose, the right drugs in the right time. So, we always believed in supervising and giving the treatment. Now, what is the aim of a TB treatment? What do you think the regimen should achieve? Number one, the regimen should cure the patient. What do you mean by cure? They should become smear and culture negative at the end of treatment. Number two, you expect fatality to come down, morbidity, mortality should come down, and also the cure should be free from relapse. The relapses should be minimal. 3, from the public health point of view, the first 2 points were from the patient's viewpoint. from the community point of view, from the TB control program point of view, you would like to make your patient non-infectious, break the chain of transmission, and also decrease the pool of infection. This is very important, since by converting the patient from smear positivity to negativity at the earliest, we definitely break the chain of transmission and decrease the pool of infection. This is from the program point of view and the TB control point of view. 4 is to minimize and prevent development of drug resistance. This is also equally important, because if they develop drug resistance, we have to go into the next level of drugs which are more toxic and not very easy to give also. So, preventing development of drug resistance is also equally important. That is also one of the aims of TB treatment. Finally, from the patient's point of view, after treating, after curing, he should be able to go back to his original job, and quality of life should be maintained, productivity should be there. Keeping all this in mind, we developed all these regimens over a period of 50 years. So, what are the principles of chemotherapy in TB? Never give a single drug, it is always a combination of drugs. That is the number 1 dictum. Number 2, the regimen you provide should be safe, safety first, and effective. Should be very effective, and it should be short also. It cannot go on for 18 months and 24 months. 6-month therapy should be adequate. So, safety, effectiveness, and short duration of chemotherapy that is also the second most important principle. Third one is making the patient take the drugs, adherence of chemotherapy, that is very important. So, here when you directly observe and give treatment, it makes life easier for the patient and for us also, and you know the lost patient, lost to treatment, this is what we say in the program. This number is considerably reduced, and you can also monitor the patient for adverse reactions and counsel them, etc. Number 4, always look for comorbid conditions like HIV, diabetes, and malnutrition. All these contribute to the bringing down the patient's general condition, and this is also very important. Now, we will come to the reasons why we said never use single drug, why it is always multiple drugs. What are the reasons? The first one is bacteriological. See, if you have millions of bacteria in a cavitatory lung lesion, I am sure naturally occurring drug resistant mutants will be there. More the number of bacteria, the resistant mutants will be there. They are called naturally occurring mutants. And second reason may be environmental. Suppose if the bacteria is in the lung, it may behave differently. If it is in the brain or bone, or the behavior may be different. And third one may be pharmacological. All these 3 factors we will go in detail now. The bacteriological basis we mentioned already, higher the bacillary load in smear positive lesions. When you have 3+ smears, definitely they will have a naturally occurring mutant of INH resistant mutants, and for different drugs, sometimes it is for rifampicin also. And always the bacillary load, higher the load, the proportion or frequency of DR mutants is high. Now, the rates of spontaneous mutation varies for different drugs. For INH, for rifampicin, ethambutol, streptomycin, that slide tells you the various spontaneous mutations. Now, preventing drug resistance. Now, the resistance can be spontaneous or random, or the resistance can be independent of each other. So, the mutation rate for INH is different from that of rifampicin and that of a combination of INH rifampicin resistance. So, generally spontaneous evolution of INH rifampicin resistance, that is MDR-TB, is very heightened to the power of 14. So, at least minimum of 2 drugs is needed in preventing the development of drug resistance. So, we said monotherapy leads to failures. The streptomycin trial clearly showed that, and then subsequently we used 2 to 3 drugs, and the evolution of spontaneous drug resistance is definitely very small when you used 2 to 3 drugs. And then so the rule is mutants resistant to one drug are susceptible to other drugs and vice versa. So INH resistant drugs can be treated with rifampicin, pyrazinamide, ethambutol, and similarly for rifampicin resistance as well. So the amplification is what we should see under program conditions. Patient may come to you with INH resistance. When you give INH, rifampicin and pyrazinamide, it takes care of the mutants. Whereas if you treat only a single drug, all the sensitive organisms are cleared, but INH resistant organisms multiply. Similarly, only INH resistant organisms, when you give INH and rifampicin alone, then they develop rifampicin resistance as well. So this is called amplification of resistance. So the number of drugs should be definitely more. Under bacteriological basis, you should know that how the bacteria behaves metabolically and how that affects the development of resistance or cure or relapses. Now, broadly, bacteriologically, metabolically, rapidly multiplying bacteria is the main group. The second group is slowly multiplying bacteria. The third group is bacteria which multiplies intermittently. The fourth one is dormant. So they are acted upon with different intensity by different anti-TB drugs. So if you look at this diagram, most of the bacilli are extracellular, rapidly multiplying, and the drugs acting on this group is listed there: INH, rifampicin, streptomycin, ethambutol, pus. But you look at B, bacteria listed under B, extracellular, intermittently, slowly multiplying organism, the number is not much, but only rifampicin is able to kill these bacteria. Go to the third one, C, intra and extracellular organisms slowly multiplying in acidic environment. Only pyrazinamide is able to kill this bacteria. So in order to tackle extracellular rapidly multiplying, intermittently multiplying and slowly multiplying, you need your INH, rifampicin and pyrazinamide. These three drugs are a must. Yet another group of bacteria is there called dormant bacilli, which is there in your body for a long time, 20-30 years, and it may present as TB, lung or brain tuberculoma later after 30-40 years. So far, we do not have any drugs for that. So when you have a regimen containing these three, pyrazinamide, rifampicin, INH, the efficacy of the regimen is quite good. Now we will go to the next factor, that is environmental factor. As I told you earlier, the type of tissue harboring the tubercle bacilli affects the drug action. Blood-brain barrier is there in the case of brain, and certain drugs may not be able to penetrate all the tissues equally. Now comes the pharmacological basis of TB treatment. When you give treatment, it's better to give all the 4 drugs together so that you achieve a peak serum level of all the drugs simultaneously. So when the peak is high, maximum bactericidal effect is observed. So what we practice is give all the 4 drugs or at the same time. Don't split the drug. Don't give INH 100 morning, 100 afternoon, 100 evening, like that. Give, if the dosage is INH 300, give 300 in a single dose along with rifampicin, pyrazinamide. Now, so what, to summarize what is achieved so far is, we have developed short course chemotherapy regimens. They provide very safe and very effective therapy for a short duration, and SCC has become the standard of care for TB treatment for the past 30 years, and they have early bactericidal activity, they also have sterilizing activity, and they can prevent the emergence of drug resistance. So we are able to achieve most of the points what we were planning initially. And early bactericidal activity helps the program. It provides indication for infectiousness, how patient become non-infectious, and sterilizing activity determines the duration of treatment. So if you shorten the duration of treatment, patient compliance also improves. This table gives nicely the early bacterial activity, sterilizing activity, and prevention of drug resistance for different drugs. You can see INH, rifampicin, and pyrazinamide, they fare very well in all the three qualities. Ethambutol lags behind. So what is the current treatment regimen? The current treatment regimen has got an intensive phase of 2 months, continuation phase of 4 months, total duration of 6 months, and rifampicin essential throughout initial intensive phase and continuation phase, and pyrazinamide is a must in the first 2 months. Without PZA, the duration will go up to 9 months. Without rifampicin, duration is definitely for 12 months. So with the help of rifampicin and pyrazinamide, we are able to achieve 6 months treatment. Now, intensive phase, we combine to achieve rapid killing of actively multiplying drugs, to eliminate naturally occurring DR mutants, to prevent further emergence. I may be repeating the same thing, but I would like to highlight how intensive phase is formed for drugs and what it is able to achieve, and smear conversion of 90% and reduces the infectiousness. Continuation phase, it kills all the remaining viable bacilli or reach a point of sterilization, and optimum duration of continuation phase is for 4 months in new cases. Now, the relapse rate of a regimen tells you the sterilizing activity of the regimen, and with the current FCC, it is less than 3%. Now, the role of domiciliary treatment, already I told you, is as effective as sanatorial treatment, and safely smear positive patients can be treated at home, and it did not added the risk to others or contacts at home. Now, what in TRC, in an ARC, we stress is directly observed treatment. When you observe treatment, you ensure the right drug, right doses, right intervals for the right duration, and you reduce the loss to treatment, that group of outcome in the treatment program. Now, coming to multi-drug resistant TB, I am sure there will be lectures on MDR TB. There are a number of drugs, group A, group B, group C, and that is beyond the, but that number of drugs are there, and we are able to treat nowadays MDR TB. Now, different drugs act at different cellular level, and this slide clearly examines and tells you the level of action. So, currently recommended daily anti-TB treatment in the WHO, it says better to give daily treatment, and when you give treatment intermittently, maybe the drug resistant, acquired drug resistance level may go up. So, WHO prefers daily anti-TB treatment, 6 months, the intensive phase and continuation phase. I thank you for patiently listening to my lecture. Hope I have made it clear how the concepts of chemotherapy evolved over a period of 50 years, how we are thankful to all these centers, BMR, CTRC in Hong Kong, for giving us a very robust treatment regimen. Thank you.